Hello and welcome to today's Center for Healthcare Strategies webinar called Maximizing Public Funding Streams to Expand Access to Evidence-Based Substance Use Disorder Services, made possible by the Pew Charitable Trusts. My name is Hadley Fitzgerald, Senior Program Officer from CHCS, and I'm delighted to welcome you here and to moderate today's webinar. The webinar is our chance to talk about a new report published today by CHCS on this topic, plus to hear from talented leaders in the field doing this work as well. We hope you enjoy today's event. At the end of the session, a brief online evaluation will pop up on your screen. Your feedback is very important to us, so we hope you'll take a moment to complete that survey. On the next slide, you'll see today's agenda, and we'll start with some introductions of today's presenters. Then we'll hear an overview presentation about the report released today called State Principles for Financing Substance Use Care, Treatment, and Support Services. After that, we'll be fortunate to hear from two wonderful presenters on work they're doing to expand evidence-based substance use services as it relates to certain principles pulled directly from the report. First, it will be a presentation on using Medicaid strategically and incentivizing no wrong door approaches, lessons from Kentucky, and then a presentation on addressing substance use disorder treatment disparities for historically marginalized groups and communities, lessons from a community-based organization, the Imani Breakthrough Project. These presentations will be followed by a Q&A, where we'll also take questions submitted by the audience. And speaking of questions, on the next slide, you can see how to submit one at any point during the session by clicking the Q&A icon located at the bottom of the screen. We'll gather those questions along with questions that some of you submitted at the time of registration and respond to as many of them as possible during the moderated Q&A discussion at the end of the session. On the next slide, you'll see we are joined by my colleague, Deisha Williams, Program Officer at the Center for Healthcare Strategies, who will give an overview of our State Financing Principles report in just a moment. She'll deliver that presentation with Andrew Whitaker, Program Officer with the Substance Use Prevention and Treatment Initiative at the Pew Charitable Trusts. Andrew is a member of the policy team that partners with states to advance reforms that expand access to effective treatment for opioid use disorders. Previously, he worked on building healthier communities at the National Association of Counties and supporting state leaders on substance use disorders at the National Association of State Alcohol and Drug Abuse Directors. We're also fortunate to hear from Dr. Catherine Marks, who serves as the Commissioner for the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. As a behavioral scientist, Dr. Marks' work has focused on state, community, and organizational level strategies, as well as policies that support recovery from the overdose epidemic. Dr. Marks previously served as the project director for the Kentucky Opioid Response Effort, with the mission of increasing equitable access to prevention, harm reduction treatment, and recovery support services throughout the Commonwealth. Initiatives include implementation of statewide naloxone distribution, quick response team, hospital bridge models, and recovery community centers. She also served as a co-investigator on the NIH Healing Community Studies and the Justice Community Opioid Innovation Network. We're also lucky to be joined today by Dr. Sherelle Bellamy. Dr. Bellamy is a professor in Yale's Department of Psychiatry and serves as the director of the Yale Program for Recovery and Community Health, and the director of Peer Support Services and Research. Dr. Bellamy is also a senior policy advisor to the Commissioner of the Connecticut Department of Mental Health and Addiction Services. She is a health equity and lived experience researcher. Her research examines sociocultural experiences and pathways to wellness and recovery and prevention and treatment. Her work has been funded by NIH, PCORI, and through state and private contracts. On this next slide is information about the Center for Healthcare Strategies. We are a policy and implementation partner, and we work with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by the Medicaid program and for services that help address health-related social needs. CHCS would like to gratefully acknowledge the Pew Charitable Trusts, who provided support for today's webinar and the report released today that Deisha and Andrew will now provide an overview of. I'll hand it over to you, Deisha.
Thank you, Hadley. Just over a year ago, CHCS partnered with Pew on developing this report called the State Principles for Financing Substance Use Care, Treatment, and Support Services, which I'll refer to it in a shortened way going forward as the state financing principles. We wanted to know what state-level financing principles or best practice strategies help create more coordinated, sustainable, and equitable financing of SUD treatment services. This question was connected to the fact that in the last decade, there have been dramatically more opportunities for states to leverage public funds for their substance use disorder treatment systems. Key among them are the Affordable Care Act, which expanded eligibility to more Medicaid beneficiaries and increased benefits for substance use disorder services. Other federal funding streams have also opened up, like the state opioid response grants from the Substance Abuse and Mental Health Service Administration and investments in the block grant for substance use treatment services. More recently are the billions of dollars for states and localities related to opioid litigation and settlements. The State Financing Principles report and a series of tools accompanying it, called the Principles in Action, also released today, are the culmination of what we learned over the course of the past year. On the next slide, you'll see that the goal of these principles is to help states use these investments more strategically to increase access to needed evidence-based substance use disorder services and to address inequities. In the process of developing these 10 principles, we involved multiple stakeholders with expertise in SUD financing or experience with accessing the SUD treatment system. Our process was iterative with multiple opportunities for stakeholders to review and offer additional insights through interviews, a convening, and a participating expert poll. We express our sincerest gratitude for all of the experts who participated in this process. If you're interested in learning more about the group, they're all listed within the report. We also want to thank our partners at Pew. Andrew, I'll pass it to you to share a few words on how you and the team at Pew hope to use these principles in your work.
Thank you, Disha. And first, I want to acknowledge Pew's partnership with CHCS on this incredible report and all the work that went into the consensus building process to get to this point. It's a year-long process and a lot of work that went into this that you'll get to hear about a little more in detail. And really the focus from Pew was to try to give policymakers more tools to be able to better spend the SUD treatment funds that they receive and align their underlying principle or state policies with those funding decisions. So something very practical that policymakers can take and use in their daily work. And Pew intends to use the principles directly in our technical assistance with 7 states over the next 2 years. And those include Kentucky, New Jersey, New Mexico, North Carolina, Michigan, Pennsylvania, and Wisconsin. So we're going to use that to do policy-focused technical assistance work with state leaders in those 7 states. I pass it back to Disha.
Thanks, Andrew. So over the next couple of slides, Andrew and I are excited to give you all a very brief overview of the principles. And this is going to be quite a bit of information coming at you fast, but we'll do our best to keep it clear and concise. So starting with principle 1 on the next slide, this principle is about leveraging Medicaid funds to expand and sustain evidence-based SUD services. This principle is important because Medicaid is the largest payer of behavioral health services and it's sustained funding, unlike some other funding sources such as time-limited grants. Fully leveraging Medicaid means examining what SUD services are currently being funded through other sources that could alternatively be covered under Medicaid, and also looking for opportunities to fund new services that will strengthen the system overall. Each principle in the report has multiple policy actions for states to consider. For this principle, one example is used value-based payment approaches that reward providers for equitable outcomes and quality services. Our report also includes examples for each policy action from states. An example for this select policy action is VBP in Pennsylvania, where their rural health model incentivizes participating rural hospitals for reducing overdose deaths, reducing rural health disparities, and increasing connections to primary and specialty care. On the next slide, we'll talk a little bit about principle 2, which focuses on directing the use of other federal funds like federal grants to the fullest extent allowable to promote infrastructure needs such as workforce development, IT upgrades, billing and claim support, and purchasing mobile services equipment, prevention services, including addressing social determinants of health, and increasing harm reduction and recovery support services, which are not always covered by Medicaid in states. This principle is important because while Medicaid is and should serve as a cornerstone to a state's SUD service system, not everything needed for a strong and equitable SUD service system is covered under Medicaid, such as hidden organizational capacity costs like telehealth equipment, or many harm reduction services like sterile syringe distribution. A select policy action under this principle is to use flexible federal funds to support workforce development, including for peer support services to the extent Medicaid reimbursement is not available. Although peer support services are reimbursable under Medicaid, workforce training is not. As a state example, Delaware is using state opioid response funds to build out the training and certification of the peer workforce within the community and the prison system. Now I'll pass it to Andrew to cover principles 3 and 4.
Thanks, Disha. So principle 3 is focused on the opioid settlement funds and using those funds as an opportunity to bring in people with lived experience into the decision-making process about allocating those funds, and also prioritizing those funds for innovative harm reduction approaches in other places where those services are not covered by different funding streams. This principle is important because it recognizes the historic nature of these funds coming out of as an outcome of the lawsuits against opioid manufacturers, distributors, and retailers, and can be an opportunity of a new way of thinking of making allocation decisions by inviting people into the process that have been most affected by the overdose crisis. It also gives an opportunity for harm reduction investments and harm reduction services that have historically been underfunded and stigmatized. And given the severity of the overdose crisis right now and fentanyl in the drug supply, states can really consider using these funds to quickly stand up life-saving harm reduction services and infrastructure, such as building brick and mortar centers and purchasing mobile outreach vehicles. So a state example of this is in Rhode Island, where people with lived experience are serving on an advisory committee that makes those allocation recommendations for the settlement funds. And Rhode Island is using those funds to in part stand up opioid or overdose prevention centers with their settlement funds. The next slide, principle 4, highlights the need to incentivize and sustain no wrong door approaches to SUD services. As probably all of you on the call know, very few people who need substance use disorder services receive any. And that's why it's so important to develop an approach that creates multiple entry points to access services, meeting people with substance use disorder where they're at. That includes mainstream healthcare settings like hospitals and primary care, but it also includes community-based settings like mental health treatment practices and harm reduction centers. Really, all hands on deck. Everyone should be involved in this. An example of state policy action here is to facilitate and incentivize integration of SUD prevention, treatment, and recovery services into medical systems, including hospitals, emergency departments, primary care, and OBGYNs. California supports what they call the California Bridge model, which has implemented bridge programs in 278 hospitals in the state that provide low threshold access to medications for opioid use disorder, peer support, and navigation to ongoing services. Now I'll pass it back to Disha for principles 5 and 6.
Thanks, Andrew. Principle 5 highlights the importance of placing patients in the most appropriate level of care, including ensuring pathways to non-residential, community-based substance use treatment and recovery support services. Many of our participating experts raised important concerns about a sort of over-reliance on acute short-term residential care, particularly given the limited evidence for these settings, and in some cases, programs which don't offer or even prohibit medications for opioid use disorder, which is considered the gold standard of care for treating opioid use disorder. These settings can also be very costly for states and potentially disruptive to patients' relationship and employment. States should support the development of community-based SUD care to ensure alternatives to residential care as a primary SUD treatment option. A policy action under this principle is to standardize routine screening and assessment of people in the SUD treatment system to ensure placement into clinically appropriate treatment and recovery supports throughout treatment. The ASAM criteria is an example of one assessment tool that is also nationally recognized, and it can guide treatment planning across the continuum of care. Illinois is a state example that we've listed in the report here. It requires SUD providers to conduct an assessment consistent with the ASAM criteria prior to admission to any level of care. And on the next slide, we'll dive into Principle 6, which focuses on historically marginalized groups, including Black, Latino, and Indigenous populations, who often face significant disparities in substance use treatment. Structural barriers contribute to these disparities and can include service accessibility, under-resourced community-based providers, and a lack of an adequate, diverse, and culturally competent healthcare workforce. This principle offers policy options to address substance use treatment disparities for these communities, specifically policy and financing options related to issues of capacity, cultural competency, and staff diversity within the SUD workforce. Policy actions in this principle also underscore the importance of ensuring representation of underrepresented communities and providers in policy discussions to build a system which is more robust, accessible, equitable, and better reflective of community needs. In the report, we highlight Tennessee's work in this area. Tennessee convened a public behavioral health workforce work group to address workforce challenges for the behavioral health system. Some strategies included creating employee-focused incentives and benefits, researching the cost of services to better understand provider costs and adjust rates accordingly, expanding internship opportunities, exploring loan forgiveness programs, and future workforce pipeline planning. I'll pass it back to Andrew for Principles 7 and 8.
Thanks, Disha. So Principle 7 is focused on how people with substance use disorder are often disproportionately involved in multiple social services sectors, such as housing or homelessness system, child welfare systems, mental health systems, and the criminal legal system. Populations of color in particular face punitive measures within these systems, which really exacerbate already existing disparities. This principle is focused on advancing equitable access and outcomes for substance use disorder treatment and recovery support services for people with multi-system involvement, as they often face a range of challenges in accessing treatment, which can impact outcomes. These barriers include fear of reprisal or loss of benefits, limited collaboration between service agencies, and siloed systems. Policy reforms are essential to align services and improve access for individuals within these systems. Principle 7 puts forth a number of different policy actions for states to consider, which include leveraging state grant funds to cross-train SUD treatment and social services staff to enhance cross-system understanding and collaboration. On the next slide, Principle 8 describes a variety of strategies that states can use to leverage local, state, and federal data, including patient-reported outcome measures, to drive more effective and equitable care and outcomes. State policymakers often have access to a variety of data sets related to SUD that include individual claims like Medicaid claims, administrative and programmatic data, patient satisfaction data, and de-identified state and federal data sets. There are a lot of challenges to harnessing it in a way that can reveal insights into SUD treatment, service trends, and disparities in care. These things include privacy concerns and a lack of standardized data collection methods. Improving that data collection in this area could enable states and healthcare systems to respond more promptly to crises and to develop strategies to address changing patterns of substance use, which often impact decision-making about how resources are allocated, such as certain geographic areas receiving more resources that demonstrate the greatest need for those resources. One policy action for this principle is to invest in data infrastructure that allows for real-time capture of critical events, such as fatal overdoses, through leveraging flexible federal funding opportunities. An example of this is California's Health and Human Services Data Exchange Framework, which is a statewide data sharing agreement between healthcare entities, government agencies, and social service programs that seeks to allow providers to access necessary information safely and securely. Now I'll pass it back to Disha for the last two principles.
Thanks, Andrew. Principle 9 outlines policy levers states can use to require specialty SUD providers to offer evidence-based treatments, including medications for opioid use disorder or MOUD, to improve patient outcomes. MOUD is safe and clinically effective at reducing overdose rates, improving patient survival, and enhancing treatment retention. It is important for specialty SUD providers to offer MOUD as a treatment option for patients, aligning with evidence-based approaches to recovery. In order to expand access to MOUD and address barriers cited by providers to prescribing MOUD, states should consider developing a comprehensive MOUD expansion strategy with robust and diverse forms of technical assistance to providers. A policy action listed under this principle is to build a comprehensive on-ramping support strategy and provide a reasonable window of time for providers to meet these new requirements before ending state funding for providers who do not meet the new requirements. And on the next slide, last but not least, Principle 10 underscores the importance of bolstering the SUD treatment and recovery support service network for children and youth. The impact of SUD on children and youth is complex and multifaceted, whether related to their own substance use or the substance use of a family member, like a parent. Negative impacts can include a higher risk for psychosocial and behavioral challenges. Accessing quality substance use treatment and recovery support services is challenging for youth. Also, schools often lack substance use services, which can contribute to this treatment gap. Given that approximately a third of the children in the US are insured through Medicaid or the Children's Health Insurance Program, these programs are well positioned to strengthen the existing service network for children, youth, and families. Thank you for listening to each of the principles. We hope that this presentation provided a sense of the type of strategies and policy actions that states should consider in developing a more robust and equitable SUD service system. And with that, I'll pass it back to Hadley.
Thank you, Disha. And before we begin our next presentation, just a reminder, please feel free to type in your questions in the Q&A function at the bottom of your screen. We're going to be collecting those questions throughout the presentations today and saving them for the Q&A portion at the end. So I'll now welcome Dr. Catherine Marks to present on using Medicaid strategically and incentivizing no wrong door approaches, lessons from Kentucky. Dr. Marks?
Perfect. Thank you. Good afternoon, everyone. It's really been an honor to contribute to the state financing principles report and also to be invited to this conversation today. And my perspective specifically is that of a behavioral health director rather than a Medicaid director. So just as a side note, in Kentucky, our Department for Behavioral Health, Developmental and Intellectual Disabilities and Medicaid are sister departments within a cabinet for health and family services. So we're in separate departments, but within the same cabinet. I hypothesize that this has been one of the privileges of my perspective, but because of that, my intention to take this time with you today to share how behavioral health partners can play a critical role in state financing of substance disorder services. And I'm going to highlight 2 principles from this report. So let's get started. Next slide, please. Or next slide after that. Thanks. So the first is to use Medicaid funds strategically to expand and sustain access to evidence-based substance use prevention, treatment, and recovery support services. Well, I could talk about a lot of ongoing Medicaid initiatives that are highly pertinent to this principle in Kentucky and other states. And I felt like I just at least needed to give honor to them before I move on to some other ideas. But things like the CMS 1115 waivers that are addressing the IMD exclusion to support residential capacity, activation of Medicaid benefits prior to release from incarceration or removal of prior authorization from substance use disorder outpatient services, and medications for opioid use disorder, expanding postpartum coverage to 12 months and non-emergency medical transportation are just examples. But as I said, what I'm going to focus on from here on out are strategies that will help empower you to talk about Medicaid changes, even if you're not in Medicaid, by contributing your own expertise. So to do that, let's first think about a behavioral health strategy that encompasses the full continuum of care so that we can ensure that we finance that. Next slide, please. So to do that, I'd like to share the specific framework that we adapted in Kentucky to visualize the substance use disorder cascade of care, or specifically, we actually used it for opioid use disorder, but it's relevant throughout. And so this should look familiar to many folks because it was adapted from the HIV cascade of care. Its purpose was to identify critical points of individual level intervention that create an effective full continuum of care. So before I read these out loud, I'll just acknowledge that this pathway is not linear or unidirectional, but because we're operating in the two dimensions, the limited dimensions of PowerPoint, it's flat for you. But so we can think about a number of things. We can think about interventions and funding to prevent the initiation of substance use, to prevent that transition from misuse, to then identify treatment need early, then provide treatment access and engagement, support treatment retention and maintain that engagement, and this is sustain remission and recovery. So we have to think about how we finance each of these stages, but there's two additional ones that are important to think about throughout this continuum. The first is harm reduction. So harm reduction begins the moment someone is using any substance, because we know that anywhere that risk exists, there's also a place for harm reduction. But harm reduction also includes principles and strategies. So it's not just access to naloxone or fentanyl test strips. It's also about the values and principles of harm reduction, expanding and continuing across this cascade of care. So I like to show folks how pervasive harm reduction is in our continuum. And then of course, building that personal, family, and community capital at all stages is so important. But I show this to you just to remind us that, and to share that for Kentucky, by mapping this out and visualizing it, we were able to really begin to think about a robust continuum that was financed efficiently by seeing it in this way. Next slide, please. And so another component of thinking strategically about how we used our funding was to establish a state implementation team. And so CORE stands for Kentucky Opioid Response Effort. That's the name we gave to our state opioid response grants, which came from SAMHSA and have absolutely been fundamental to some system transformation in our state. But what we did is we formed the state implementation team in 2017, again, as a result of that SOR funding, and it has served so many functions. It supports structured representation. So all of these entities, governor's office, our cabinet for health and family services, which is where, as I said, we're in, along with public health, Medicaid, our child welfare, justice and public safety, our courts, university and community partners, by bringing folks together in one space. Not only have we been able to kind of create that structured representation to talk about funding, but we've just had immense coordination in our activities. And so anytime someone gets a grant, they come on and they talk about what that grant looks like. And we have had opportunities for really great coordination as a result of that. People show up and talk about issues in gaps in funding or emerging problems when COVID first came and we did not at that time have a systematic distribution of naloxone in all of our jails. We rallied together as a result of one call and were able to ensure that every individual who was released from incarceration through executive orders also had naloxone in hand. It's a tool for relationship building, and I can't say enough about the relationships that are essential to support these discussions about financing, keeps us aware of emerging issues, and also has helped us to create a common language to communicate. You see the NIH Healing Communities initiative in there. I just want to flag that for you. We've been so grateful in Kentucky to be one of our states participate in the healing community study, and having that as an additional research arm that's now innovating into CORE has been really exceptional. So if you're thinking about how you might start something like this in your state, find state opioid response project director or state opioid response state opioid coordinator to talk about a similar idea. Next slide, please. So if we move into something a little bit more concrete, again, under this, this first principle of access, I wanted to share about the work we've done with our Kentucky Primary Care Association to expand substance use disorder treatment, specifically for federally qualified health centers, FQHCs, or rural health centers, RHCs. And we did this because we know that substance use treatment within primary care specifically increases community treatment capacity and lowers barriers to access. And in Kentucky, there are dozens and dozens of FQHCs and rural health clinics in our state, so there's immense potential here. But we knew that going one by one as a state agency was going to be incredibly inefficient and not feasible. And so instead, we partnered directly with our state association that represents nearly all of these entities to do two things: to install change capacity into their very infrastructure of the organization, and to empower their advocacy arm to use the work we were doing, which included funding peer support specialists, case managers, client transportation, those pieces as a pilot to begin to explore billing capacity, to think about big P and little p policy changes, some of which included advocacy to Medicaid, and also thinking about what would be needed to sustain the practice changes that were initially funded through the SOR grant. And as a result, I feel pretty confident in saying that KPCA has been able to work even harder and more effectively to expand peer support specialist billing within the rural health clinics. And we're able to use the outcomes and infrastructure that was built through this pilot funding really successfully. And so the strategy of using umbrella organizations that participate in state level policy decisions is particularly successful. I'll give another example soon around the Kentucky Hospital Association. Next slide, please. So we're going to switch over to principle 4, which is to incentivize and sustain no wrong door approaches to substance use care, treatment, and support services. And so I just want to quickly sit and think about what we mean by this principle. And so what it means for me, at least, is whether you walked into a hospital or a health department, a police station, primary care clinic, courtroom, we could continue naming the settings, that you've moved closer to services, not further away. And I'm a big fan of this idea that we're bringing doors to people and where they're at and not waiting for them to find our doors. So a couple models I'll highlight. Next slide, please. The first being kind of the new classic of no wrong door policy. And you heard this mentioned earlier as the Bridge model for hospitals. And California Bridge, I'll put a plug in, has just done an amazing job at translating this vision into a very concrete set of policies and practices that folks can tap into through a really user-friendly website. But the concept is simple, right? So when people come into the hospital, we identify the need, we engage them and offer the life-saving treatment services that we would offer for any other medical emergency. We treat our opioid withdrawal in this case as a legitimate medical emergency through the use of buprenorphine, incredibly effective and safe. We connect them with services, harm reduction, especially obviously providing naloxone, and also overdose education and prevention. And then we follow up. We create infrastructure for peers and others to continue to provide access to the medication and any other services folks might be ready for. And so in Kentucky, we seeded this model by using SOR funding specifically initially. And from there, we're able, through wonderful collaboration with Medicaid, to add peer support services into the emergency department as a billable service through Medicaid. And it took just a state amendment. And that was a remarkable success that came from this initial piloted work with our, at the time, just 10 hospitals. And just like Kentucky Primary Care Association, we've now partnered with Kentucky Hospital Association to take this model statewide. Next slide, please. The other model that I wanted to share in this vein of no wrong door approach is the quick response team. And so again, it's this taking the door on the road idea, because we know a couple things, right? We know that structural barriers are disproportionately impacting service access for specific populations that have been marginalized and minoritized. And we know that stigma and enacted stigma, which discrimination, continue to deter service access. And so Quick response teams are really a definition of outreach and engagement. They include assertive outreach to overdose survivors and their families by a team of peers, first responders, treatment providers, whatever is right for that community. Their visits occur within 24 to 72 hours post crisis. They facilitate service linkage. They conduct follow-up visits. They also do a lot of canvassing and community engagement in the interim to ensure that they have the right connections they need in the community. And their message is really simple. It's, we're glad you're okay and we're here to help. And so what's been beautiful about working in the quick response team model is we've seen so much emerge nationally that's going to be funded through CMS and through SAMHSA and other pilots, 988 crisis co-responder models. There's just so many initiatives that quick response teams are able to plug into. And because we were able to seed these, again, a little sooner, a little earlier in the continuum of time, we are able to just plug these in, the lessons learned, the capacity so nicely. And I could go on and on about other models in this vein of the principle. CCBHCs, for example, or mobile treatment services or mobile recovery community centers. Those would be great examples. But I'll just wrap up with a kind of just a few final thoughts. In really, it's what I said at the beginning. I just want to encourage you to see your agency's role and the opportunities for thinking both comprehensively and collaboratively about financing substance use disorder care. I want to encourage everyone to think creatively and aggressively about braiding funding to solve those gaps in systems, and think about how you can be using these pilot funds to demonstrate future investment, support the transition to sustainable funding, and so importantly, to rally support for the vision and the opportunity and the outcomes through these pilots. And so with that, I believe that was my last slide. I will turn it back over to Disha, and thank you so much for the time today.
Thank you, Dr. Marks, for this really rich presentation on what's happening in Kentucky. We'll hear one more presentation before we break into the Q&A. So I'll now pass it to Dr. Sherelle Bellamy, who will present on addressing substance use disorder treatment disparities for historically marginalized groups and communities, lessons from a community-based organization, the Imani Breakthrough Project. Dr. Bellamy?
Good afternoon, and thank you so much for having me today. Before I begin, I actually just want to say thank you to Dr. Marks. It really is a pleasure to be with you and to learn from you as the Commissioner of Kentucky. And I really appreciated the cascade of care and also just your emphasis on the importance of relationship building. And I think that's just critical to what it is that I'm going to be talking about today as well. I'm here today to present to you the Imani Breakthrough Project. It's just an example of how to address a few of the principles, specifically Principle 5 related to community, as well as Principle 6 related to addressing some of the racial ethnic disparities. Next slide. So I just want to do a brief land acknowledgement. All land in Connecticut was once Native territory. It is our duty to acknowledge that many of the institutions where we work or conduct research are indeed on Native land. So it's really important that we give thanks. Land acknowledgements do not exist in the past tense or historical context. Colonialism is a current ongoing process, and we need to be mindful of our present participation. Next slide. These are the only disclosures, and you'll learn more about, where we're funded from the Connecticut Department of Mental Health and Addiction Services, as well as from NIH. And I just wanted to mention that all images are copyrighted or are publicly available. Next slide, please. And Imani is a full team of people. I certainly stand on the shoulders of many people in doing this work. So special thanks to my co-PI, Dr. Ayanna Jordan, as well as to all of the community partners that help pull together the work of the Imani Breakthrough. And this list continues to grow and grow almost every time we do this presentation. But also a special thanks to the churches, pastors, facilitators, and people with lived experience attending Imani. And truly, this is in memory of the many people that we have lost to the opioid epidemic. And I just wanted to say that personally, having lost my cousin, Jasmine, I also dedicate this to her, who died at age 33 to a opioid epidemic just last year this time. So this is real. It's real for me. It's real for many of us who are on this call and many of us in our community. Next slide, please. These are just our Imani facilitators throughout the state of Connecticut. Next slide. And these are our Imani pastors. So again, thank you to all of them. Next slide. And I like to just begin with the poem. This is a poem that was developed by my friend and colleague, Imani Harrington. Imani is a playwright in San Francisco, but also a woman living with HIV. And this is a poem she wrote. We need you. We need you, our brothers, our sisters, our people. Help us reaffirm ourselves in loving ourselves. Hold us when we can't stand, because soles of shoes have traveled on our backs for so long. We need you, our brothers, our sisters, and our people. And to me, really, again, that importance of relationship building, this really gets at the core, the essence of why this is important in the first place, because this really is about helping people affirm themselves and loving themselves, but also it's about helping ourselves affirm ourselves and loving ourselves. Next slide, please. So why the Imani Breakthrough? By the way, Imani stands for faith in Swahili. And through Imani, we aim to promote health and healing, not for ourselves, as well as for our communities and neighborhoods. And how is this accomplished? Through a participatory process where we are creating a sense of unity and creating a sense of collective responsibility, two elements that we see are key features of the Imani process, and also creating a sense that we're all in this together. Next slide. So the evolution of the Imani program, again, I wanted to just point out, next slide, please. I wanted to point out that we first started with DMS funding through the SOAR, State Opioid Response Funding, through the Connecticut Department of Mental Health and Addiction Services in 2017. And we received this funding to pull together something addressing African Americans, Black individuals, as well as Latinos, Latina communities. And initially, we started with just a focus on Black communities, and we started with 4 churches, and then we further adapted to then spread out Imani to an additional 4 churches, which were Latino churches in the state of Connecticut. As you can see from this, we now have additional funding. Dr. Jordan and I received funding through the NIH, through the U01 mechanism. And we have a randomized clinical trial. But it was the work of SOAR that gave us the findings that we needed to fight, to ask for more funding in this area. Through the NIH U01 process, this is now a randomized trial, and it offers a telehealth MAT option. And telehealth is happening in the churches. I just have to say that because that's an important part of that project. In 2023, we have now 2 other states who are doing the Imani project. some using SOAR funding and some using other, sort of state and private funding. One is through the Rhode Island Department of Behavioral Health Care, and we're working with 2 churches in Rhode Island. They just started, I think, just in August. Really excited about the work they're going to be doing. And we also are working with Dr. Rochelle Dunham's team, the Metropolitan Human Services District in New Orleans. And we were out there in July to do training with their team, and they are also doing Imani with 2 churches. So we're happy to see other states really taking Imani and running with it. Next slide. Next slide. So why Imani and why with Black churches and Latino churches, and why now? As you can see from this slide, Black and Latina with SUDs continue to die at a disproportionate rates. Those numbers continue to increase. You can just see that by the graph here. And this is often due to the lack of effective OUD as well as AUD treatment for Black and Latino people. Next slide. I also wanted to point out from that slide that this is primarily due to what we're all dealing with in terms of our national crisis, as the rates of fentanyl as well as xylazine overdose continues to be a major issue. I also just wanted to say that a part of this call to action is the focus on that, Black and Latino people are continue to die at a disproportionate rate, much earlier than the rest of the population. And that rate is looking to be about 15 to 25 years. Again, calling for us to do more in this area. Next slide. Some of the things I wanted to point out here is that for racial ethnic minorities in the US, they're less likely than their white counterparts to seek mental health treatment, including drug and alcohol treatment. And when they do, they often are less likely to start it. So engagement is really key here. While there may be access, engagement and staying in treatment continues to be an issue. And this is where Black and Latino churches can be helpful. Next slide. They can also be helpful in addressing some of the disparities in terms of the OUD outcomes. And by addressing those disparities, I mean by addressing many of those social determinants of health. And for our group, we're seeing issues around racism, we're seeing issues related to vicarious trauma, really seeing like, many of us who are surviving the loss of those to the death of overdose. We're seeing many people with legal involvement who are about 75% of the people involved in our program have had some involvement at some point with the criminal justice system. We're seeing that many of them have food insecurity challenges, lack of family support, dealing with issues of hopelessness and poverty, etc. Next slide. Black churches and Latino churches have been in existence for a long time, and they continue to be the go-to, and particularly for Black and Latina individuals. They see religion and spirituality as a source of coping with psychological distress. In urban communities, we're also seeing that 65 to 80% of individuals are attending church regularly. And for Latinos, 75% of individuals are attending church regularly. And I often like to say, even for those of us who may not be attending church, if you have a mama like me, she's somewhere praying for you right now. Many studies also highlight the importance of church in drug and alcohol treatment. Some of them have substance use ministries. Some of them are doing mental health ministries. Many of them are doing outreach. So there's a lot that's happening in the churches already. So it's really important that we sort of capitalize off of what's currently happening in our communities. Next slide. So Imani was developed through a process of the community really coming together. We really took our time to meet with church members, people with lived experience of substance use, people from community, family members, people from neighborhoods, social workers, psychiatrists. All of us came together to really develop what we called a learning community, to have conversations about this. We did conversations throughout the state of Connecticut to really get input from people who have been there about their experiences. Next slide. And I just want to point out Reverend Robin Anderson. She's our church liaison, and this work would not be possible without her assistance. Again, it's while I represent Yale University, this work is not possible without the work of community. Next slide, please. So two models came together to develop the Imani Breakthrough. One is the citizenship, the 5 R's, which was developed by my colleague here at Yale, Michael Rowe, as well as the 8 Dimensions of Wellness, which many of you should be familiar with from my colleague, Peggy Swarbrick. And really, it's about how can we combine those 2 elements so that people truly have a chance to not only to survive, but to thrive in their communities. What happens after they decrease their substance use? Are there ways that they can focus on regaining their relationships with community, regaining their relationships with their family members, regaining their relationships with employment and other things that are going to be possible, that other things that they need in order to sustain their recovery and community tenure. Next slide. Imani takes place over 6 months. And initially, it only was supposed to be for 12 weeks. But the pastors and the church members, and this is the community participatory aspect of it, they said, no, we need more. We need to have a next step component. And that next step component consisted of an additional 10 weeks. And those 10 weeks are focused on mutual support. What we often find during that aspect of it is a concentration on advocacy. Some of our participants really want to do more. They talked about going to the legislative office buildings to advocate on behalf of people living with substance use. At the end of those markers, we make sure to have graduations to celebrate these achievements. And we invite community members, as well as family members, as well as state officials to come and to acknowledge those individuals. Next slide. So what's unique about Imani? Imani is unique because one focuses on harm reduction, and harm reduction happening in faith-based communities is huge. It's really important, again, that we talk about harm reduction more broadly. And I really like that Dr. Marks really talk about, it's not just giving out, naloxone. It's also about the values and the principles of harm reduction. We talk about the importance of mutual support, intensive wraparound support. So the facilitators are also coaches to individuals. Each church has to have a person with lived experience who could serve as a facilitator as well as a church member. Often the church member is also an individual that has their own experiences of substance use or someone in their family. It's important that we train people on the elements of the Imani philosophy. Really, most of that is really lending itself to addressing issues around equity, meeting people where they are, as well as coming from a culturally responsive perspective, and even utilizing all of what we've learned over the years in terms of peer support. Next slide. So briefly, from 2018 to 2023, we were able to collect some data from the Imani SOAR individuals and those numbers continue to improve and increase. Approximately 1,700 people have come through our doors of the Imani projects in Connecticut alone. And this, again, is huge because many of the other projects that are SURE funded were not getting numbers as high as this. Next slide. People often ask, who are these folks? And I just want to point out, these are the folks that we need to be reaching. As you can see, many of them have experienced issues related to incarceration, dealing with their own personal violence, as well as, I also wanted to point out that 67% were currently were not receiving substance use services. Next slide. And, these next two slides just really talk about the results. So as you can see, this is why we were able to get NIH funding, is because Imani produces results. We were able to show both in terms of the 8 dimensions of wellness, next slide, as well as the citizenship domains, that Imani did improve, wellness as well as these citizenship domains over time. Next slide. And people are coming and completing again. While those 42% is huge in terms of people who are actually staying with the program. Next slide. I just wanted to point out a few of these. I know my time is running out, but I just wanted to say that read this one. The last 15 years of my life is I did a lot of programs and never finished. I was super negative about life. I never had self-worth. There are other people just like me that have a lot of problems. Graduating from this program opened doors. I got my GED and I'm going to see what my purpose is. Next slide. So just in closing, in terms of successes, Imani is saving lives actively. We give out, naloxone kits, and, not only have our facilitators saved lives right in the context of the Imani groups, we also have given out kits to our participants, and they are doing the same and saving lives in their own communities. It's really critical that you connect with communities and other systems of care. It's critical that we rely on what's going on in communities. We rely on our community partners. Going out to meet people where they are at is critical as well. Doing outreach in those communities and places where people are going. They're not just going to show up at the churches. Many of them have even been, sort of through their various different experiences, may have not even relied on the church or felt shame and guilt because of the church. So it's really important that we go out to meet them where they are. I also just wanted to say that, as well as it's important that churches are taking ownership. Churches need to, and community needs to take ownership, and that we as partners need to allow for that to happen. Next slide. These are just some additional engagement strategies. And I just want to say again, thank you for this time to present on Imani. Thank you.
Thank you so much, Dr. Bellamy, and appreciate all the reactions through the icons coming in from the audience and the questions that we've received. So now we've reached the portion of the webinar where we are going to open it up to Q&A. So I'm going to ask Dr. Bellamy, Dr. Marks, and Andrew to come on camera, and I'll field some questions for each of you. And let's see, I'll start with Dr. Marks. Dr. Marks, we received a number of questions at registration, and including in the chat today a bit about families, youth, and substance use. So I wanted to ask you, how has Kentucky sought to maximize SUD funding strategies for families with child welfare involvement as a result of SUD?
Yeah, it's been so important in our partnership with our child welfare organization, DCBS, Department of Community-Based Services, has been vital for this. So I'll give an example again with using SOR funding. And so what we did was to start by funding 3 initiatives that are led by our child welfare organization organization, K-STEP, which is Kentucky Strengthening Ties and Empowering Parents, START, which I think more folks are familiar with, sobriety treatment and recovery teams, and then a third one, TAP, Targeted Assessment Program. So each of these had a strong evidence base, some foothold throughout the state, but they lacked any focus on opioid use disorder. They weren't necessarily in areas of the state that had highest impact of opioid use disorder. They didn't have strong linkages to medications for opioid use disorder in them. And so we fund to expand the expansion of all three of these programs. What's most important about this transition, though, is that we did this with the intention of Family First Prevention Services Act being able to step in eventually and to take over the full funding of those. And so we kind of precisely selected the scale and locations and capacity so that we could make that transition in the future, and were successful. And so we took, I would say in total, about $3.5 million of SOR funding annually that was able to be switched over to fully sustainable through Family Prevention Act, which was a huge success for us. And these are impactful programs. The Targeted Assessment Program, I'll name especially, the idea is you co-locate assessors in child welfare offices whose full-time job is just pre-treatment motivational interviewing, barrier reduction, linkage to services, and their outcomes are remarkable. Of the 583 cases that were closed in a single year that had child welfare involvement, 79% were successful preventing the child from being removed from the home, and remaining 17% for reunification within that year. And so those types of programs have been really impactful for our state.
Thank you. Thanks so much for sharing that information about, that really important population as it connects to this work. My next question is for Dr. Bellamy. We had a few questions in the chat related to the Imani Breakthrough Project and whether the program connects folks to medications for opioid use disorder. And if so, has there been resistance about connections to MOUD? And I think that falls under, we can sometimes consider, even though MOUD is treatment, it is sometimes considered a form of harm reduction as well. And if you've had any success in explaining harm reduction strategies, including MOUD, to faith-based organizations and churches.
Yeah, thank you. Those are great questions. I see a couple of them in there. I wanted to say that what's really helpful. So I want to talk about Imani SOAR first, because with the SOAR funding, definitely the whole point of Imani is to engage people with harm reduction and, as you mentioned, medication for addiction treatment. And that's across the board. When we're talking about medication and treatment, we're not just talking about MOUD, we're also talking about just helping people to just sleep better, to eat better, to do all those things that they need to do. Many of them have never even been connected to any type of mental health services. As you can see from those numbers, 67% were not currently connected. So it really is about treating the whole person. And again, as people are finding out about they're dealing with their substance use challenges, we also know that they then start, or are in need of dealing with many of the health challenges that they have not been able to address over the years. So that's also critical. The challenges remain, however, which is why your work is really important, which is really like, how do we better develop culturally responsive services? Because the numbers are still low. Our engagement numbers across our state, as well as many states for Black and Latino individuals, still tend to be on the low end. People, even when they start, they don't continue with the MAT. So we need to do better there. what has been effective, again, is having these linkages with community and having community, just even the facilitators, just even taking people right to the sites and serving as sort of navigators. It's also been really helpful having church leaders talk about the importance of harm reduction in MAT. That's vital because oftentimes if there's stigma around taking medication, around MAT, it's really important to address this issue. While we do have the Imani program, what's also been critical, as I mentioned, our Reverend Robin Anderson developed a series of educational conversations with the community that's been crucial to this, because without that, it's not going to work. At the same way that the participants need to be educated about harm reduction in the community, so do all the people in the church as well as the people in the community. We need to make sure that information is getting out to everyone.
Dr. Marks?
Yeah, could I, that was wow, a beautiful response. Thank you. Two things that came to mind for me, actually just one thing specifically. In Kentucky, we've managed to come a long way in our state with harm reduction. We have 84 active syringe service programs right now. But there was a book that I read. I just want to put a plug in for it. It's called Undoing Drugs by Maya Solovitz, How Harm Reduction is Changing the Future of Drugs and Addiction. This book is amazing for communicating the principles of harm reduction, strategies and principles, and parlaying the relationship in the aligned ideologies of the 12-step program and harm reduction. And so if you haven't read that, I really encourage you. It's just a great book.
Thanks. Yes, we definitely welcome those recommendations specifically as well. Also, just, jumping back into questions from the chat, I have one for you, Andrew, about the Support Act and the exclusion. Can you offer your insights as to how the Support Act reauthorization will impact states' ability to continue improvement of access to SUD treatment? And most specifically, how eliminating the IMD exclusion would be implemented should that component of the reauthorization become a reality?
Yes, thanks, Hadley. And I can't speak to how it would be implemented. I can touch base with some of my colleagues that do our work on our federal side and follow up with you after the webinar, but this is a big issue in states, obviously, the IMD exclusion, and whether you have the capacity to treat people in residential care above 15 beds. So it's a massive issue for states to face, and there are people on both sides. There's a real privacy concern, and then there's real capacity concerns for states to be able to, they can currently file 1115 and actually get an exception already, but this would avoid that process if it removed it completely. And so there's a lot of battle in terms of those two sides of the coin of capacity versus data. And so it'll be an interesting question of how that is implemented if it does actually stay in the reauthorization, and I'll follow up with some more details about that.
Yes, thanks so much for that, Andrew. And I think, correct me if I'm wrong, Dr. Marks, but I think Kentucky was one of the states pursuing the IMD exclusion waiver through the 1115 waiver. Yeah. And another question for you, Dr. Marks, having to do with rural communities. So I was wondering if you could talk, since many parts of Kentucky are in rural areas, can you talk about funding and policy strategies that Kentucky is using to reduce overdoses in rural communities? I know you touched a bit on FQHCs and their potential, and I'm sure they're often in rural communities in Kentucky. But if there's anything further you'd like to share, we'd welcome that.
Yeah, the first place to go to is we looked at the data and we shared the data. We know that data is visibility and visibility is priority. And so we needed to look at the impact at the county level of overdose burden, but not just of overdose, but a couple other factors. And so what we did is we created a risk index score for each community and then mapped that across the state and started sharing it with everyone to show where these by geographic geographic region disproportionate impacts were. That allowed us to build the justification and the shared understanding of why we were prioritizing our funding in certain areas. And so we did work to align some proportionate funding to those rural communities given their greatest burden. What's been interesting to watch is that risk index maps move over time. We've watched the impact move from southeast rural Kentucky, kind of more central into the state. I just go there every time in my head. But so once we identified where we needed to do the work, the next thing we said is that we don't have the answers, local communities do. And so we built notice of funding opportunities to say, here's the parameters. This is about opioids at the time. It's expanded to stimulants. This is about evidence-based practices and evidence-informed practice. Tell us what you need, and we will look to fund that. And so we've done that with our health departments. We've done that with broader calls for increasing access to services. We've taken some of our funding and put it with another partner organization so that they could then disseminate the funding, thereby reducing some of the structural barriers that people experience to applying to the state with our big, burdensome, complicated processes for applications. And so those notice of funding opportunities were important. Supporting local developed anti-stigma campaigns. People need to see the faces of their community members in the messaging. And we did that through a statewide project called Unchained Kentucky that is built at local levels. And then creating flexibility in the funding parameters. What our urban environments need is not always what our rural environments need. And so allowing them to say, these are the types of resources we need. It can be taxis and Ubers in Louisville, but the infrastructure doesn't exist in Perry County. And so we have to change it. Perry County is in Eastern Kentucky. And I'll say that now that we have risk index maps for opioid use, for rural communities, in the past couple of years, we've shifted to index maps, really talking more about race, ethnicity, and other structurally determined factors that are increasing rates of overdose death disproportionately. So it's been a good model to replicate.
Well, thanks so much for sharing that important work with us. I'm going to have a question for Dr. Bellamy, and it's related to the behavioral health workforce, because we often hear part of the challenge of addressing the overdose crisis or substance use crisis in general is behavioral health workforce shortages. And we know these shortages are widespread across the country, but there's also a particular lack of availability for culturally and linguistically effective providers, which perpetuates health disparities. So given your experience and your expertise, what would you say states might consider to strengthen and diversify the SUD workforce with the public funds available to them?
Thank you for that question. I can talk about that forever. I just wanted to say that Disha actually and the principals actually have addressed it in terms of sort of developing a pipeline, developing ways that people can enter and be motivated to join and work in, particularly in substance use. It's really about also marketing to, again, churches, communities, neighborhoods, the work, the importance of doing the work. I think that, we don't talk about this, but there's also a stigma that's related to working in the area of substance use as well. So we need to continue to figure out ways to effectively address that. We also need to expand our definition of what providers are. We know that we've done a lot. We're doing a lot nationally in terms of bringing more peer supporters, as well as recovery coaches, as well as lived experience, leaders to this work. So really expanding what we mean by providers. And that's what I love about the work of Imani, because it expands it to the churches, expands it to the community. And when we talk about no wrong door, yes, there are no wrong doors, but what are some alternative doors? How can we provide funding to other people so that they can also get an opportunity to do the work instead of funding some of the same people that we've been funding over and over again. But giving new opportunities to people is going to be really important in this work.
Absolutely agree. I see lots of heads nodding there. I think we have time for one more question. So I'm going to pose this one to you, Andrew. just in terms of, given the technical assistance that Pew provides in states in addressing the overdose crisis, what are you seeing in states in terms of coordinated approaches to targeting publicly available SUD service funds towards evidence-based and evidence-informed services? Obviously, we have two great examples, today with the SOAR-funded Imani Breakthrough Project and many examples that Dr. Marks has shared. But from a more bird's eye view, we'd really love to hear your perspective.
Yeah, there are two things I would highlight, and actually, Kentucky really does this well, and I've gotten to see Kentucky do this up front with some technical assistance we provided in previous years. And one thing is funds come from a number of different sources, and they go to different sources in the states. So an individual or an agency, they're going to different places. So coordination doesn't come naturally because of that. And so it's really critical that states use formal structures to create that coordination. Kentucky does that really well, but there are a lot of states that don't. And so they're really across from Medicaid to the behavioral health, SAMHSA, primary SAMHSA funding, there's just no coordination on what the funding priorities are. And so they're often working at odds against each other on what that looks like. And of equal importance to the funding part is reviewing the alignment of your funding with underlying state policy. So oftentimes there are funding priorities that are put in place that are good intentioned and going in the right direction, but underlying state policy works at cross purposes to those funding priorities. And so Kentucky's another great example. We worked closely with them when they reviewed their OTP regulations and made significant reforms to do that. And that was we recognized that we have a priority to expand MOUD in the state, and reforming our OTP regulations is a critical part of that. And they did it pretty quickly and seamlessly. In my experience with state regulatory reform, sometimes it can take forever. So those are two critical things I'd highlight.
Thank you so much, Andrew. So with our just one last minute remaining, I'm going to ask that we pull up the slides, and I'll just point to some resources that were released by CHCS today. The first is the report itself, the State Financing Principles Report. Additionally, there is a set of principles and action checklists that are also out today. These tools outline concrete strategies to guide state investments in evidence-based peer supports, medications for opioid use disorder, and harm reduction services. And on our next slide, you can find information about how to subscribe to the CHCS email updates list, and a reminder to follow us on social media. And on the last slide, I just want to give a huge thank you to Andrew, Dr. Bellamy, and Dr. Marks for your wonderful presentations, your work, your passion, your insights. We greatly appreciate it. We want to thank also everyone for attending and for submitting your questions. You will receive an email with the recording and the slides, so please feel free to share those. And thank you also in advance for completing this survey that will pop up on your screen momentarily. Have a great rest of your day. Thanks, everybody.